Thank you, Kim. All right, I think let's go ahead and get started. We have a fantastic turnout today, and I'm delighted to welcome you all to the Department of Medicine Grand Rounds on this very last day of February. And I'm also delighted to welcome Dr. Molly Perkins to speak with us today. Dr. Perkins is a social gerontologist and medical sociologist with research interests in social determinants of health and disparities, aging in minority and vulnerable populations, functional wellness, and long-term care. She's a National Center on Minority Health and Health Disparities Scholar and a Fellow of the Gerontological Society of America. A primary focus of her work has been on addressing social, behavioral, and environmental aspects of chronic disease management. Dr. Perkins co-directs the NIH Roybal Center for Dementia Caregiving Mastery here at Emory and is the director of the Emory NIH Center for AIDS Research, HIV, and Aging Research Cluster. And I've had the opportunity to work with her a little bit in that space, which has been fantastic. In addition to her primary appointment as an associate professor in our Division of Geriatrics and Gerontology, she's a member of the graduate faculty of the Emory Department of Sociology. She has a joint appointment as a research health scientist at the Atlanta VA Medical Center, where she's the site director for research for the Birmingham Atlanta VA GREC. Her recent grant funding is as a PI on a 5-year longitudinal study funded by the National Institute of Aging on investigating informal caregiver involvement in end-of-life care of persons with advanced dementia and assisted living. And that's the topic that we get to hear about today, and which I'm anxious to learn more. So her talk is entitled Assisted Living, the Interface Between Formal and Informal Care. And Molly, thank you so much for joining us.
Okay. Good afternoon, everyone, and thank you for that nice introduction, Dr. Armstrong. It's truly an honor to have this opportunity to give Medicine Grand Rounds today and to share some of my work in the assisted living setting with this audience. So I guess I will, at this point, try to share my screen and pull up my slides. So, trying to get to the slide. All right. There we are.
That looks perfect.
All right. So as Dr. Armstrong said, and as the slide shows, I'll be speaking today about the interface between formal and informal care in the assisted living setting. And in addition to other types of research, I've been conducting both qualitative and mixed methods research in the assisted living setting for, oh my gosh, a little more than 20 years now, beginning as a graduate student, and have seen a lot of changes in the industry over time that I'll touch upon. I'd like to note that much of this work has been ethnographic in nature, where we've spent as long as 2 years in the various research sites observing daily and weekly activities as well as change over time. And I'm not a clinician, I'm a social scientist, so much of what I'll be presenting today will focus on the social and behavioral aspects of care in these unique and rapidly evolving care settings. And I'm hoping that these insights will be useful to those of you who see assisted living residents and or their caregivers in your clinics and or have family members or friends living in these communities. And I'd like to note that a hallmark of my team's work, which is based here at Emory and also over at Georgia State University, where that work is led by my close colleague, Dr. Candace Kemp at the Gerontology Institute, is a focus on diverse care settings. We really are one of the few teams in the US to focus on the experience of Black residents, low-income residents, and rural residents, for example. And most other existing assisted living research includes predominantly white, urban, upper to upper middle class samples. And this was the population that this industry originally targeted when it emerged in the mid-1980s. So I have no pertinent financial disclosures. And so my objectives today are to describe care networks in assisted living and discuss the interface between formal and informal care, provide some background on assisted living and important context related to these care networks. And then I'll discuss the rapidly changing care environment in assisted living, including the impact of the pandemic, and describe how these trends shape care and care partnerships. So to start, I thought it'd be useful to define the care setting I'll be discussing. For many of you, this information may not be new, but I find when I give these talks that enough people find the context useful. The standard definition is that assisted living is a non-medical, community-based residential care setting for older adults who are not in need of skilled nursing care, but are unable to live independently in the community. Assisted living was designed to be more home-like than a nursing home and to fall somewhere in the middle of the long-term care continuum between one's own home and nursing homes. And in most states, these communities are not licensed to provide 24-hour skilled nursing or medical care. Most care is provided by unlicensed, low-wage, direct care workers with limited education and little or no healthcare training. So although assisted living includes under its umbrella a low-income board and care home model that I'll talk about in a bit, the ideal of assisted living was developed to cater to an affluent clientele and provide a broad array of personal care and supportive services in a home-like environment. And developers and owners in the hotel and real estate industry have invested heavily in this industry, and some chains carry their names, such as Marriott, and I'm sure you've all seen those. Assisted living was developed as a social model of care as opposed to a medical model of care, with a philosophy that emphasizes consumer choice and autonomy, dignity, privacy, and individualized care plans. And the ability to age in place is another core philosophy of this setting. An aging in place policy in assisted living is aimed at helping residents avoid being discharged to a higher level of care or nursing home prematurely. And as residents of age in place in assisted living, death and dying in the setting, and I'll be talking about that quite a bit, have become increasingly common. Assisted living has increasingly marketed their communities as providing specialized dementia care, and many families and residents living with dementia prefer this setting over more institutional care in a nursing home. And recent national figures show that as many as 2/3 of all residents in these settings have some form of dementia, and up to 90% have some level of cognitive impairment. So these are really dementia care settings. And as also noted on the slide, assisted living more frequently provides specialized dementia care services, including care provided in separate secured memory care units compared with nursing homes. About 10% of assisted living communities serve only residents with dementia, compared to only about 0.4% of nursing homes that specialize solely in dementia care. And just in the last 5 years, we also are seeing an increase in residents with advanced dementia at end of life in assisted living. And this includes residents who are nonverbal, who cannot feed themselves. 5 years ago, most of these residents would have been discharged to a nursing home once their dementia became more advanced. I currently have an ongoing study that Dr. Armstrong spoke about, and I'll speak more about also, that focuses on the needs of informal caregivers, and that's family and friends who are providing care for residents with this advanced dementia in these settings. So this slide gives you an idea of the number of assisted living communities in the US compared with the number of nursing homes. Based on a biannual national survey of long-term care settings with 4 or more beds, there were close to 30,000 assisted living communities in the US in 2016, compared with almost 16,000 nursing homes nationwide, although the number of certified nursing home beds has remained substantially higher. And this decline in the number of nursing homes nationwide, down 7% from 2000 to 2015, parallels continued growth in the number of assisted living communities in the US. Assisted living is an increasingly popular long-term care option and the fastest growing care setting for older adults in the US. Many refer to it as a wave of the future. And recent figures show that we have 900 of these communities here in Georgia. So as indicated in this slide, more than half of assisted living communities, 60%, are smaller and range from 4 to 25 beds. Many of these are low-income homes, and I'll talk about the different models of assisted living care in a bit. However, as indicated in this slide, most assisted living residents live in the larger, more upscale homes with more beds. So the types of homes that fall under the assisted umbrella vary quite a bit, but can generally be described in terms of 2 models that you see here. The board and care home model represents a long tradition of care in the US that dates back to the early 19th century, when dependent and displaced people were cared for in charitable private homes. This model of care primarily serves low-income, rural, and racial and ethnic minority residents, including many with serious mental illness. Many of these residents pay for their care by signing over their supplemental security income SSI check, which is currently $914 per month for an eligible individual. And some of you have probably treated these residents at Grady. The homes often have names that reflect the name and or values of the provider, such as Lucy's Loving Care Home or Blessed to the Max. And many residents living in them lack involved family and look to the provider to fill that role. Wait, and let me see, I go back. The contemporary assisted living model surfaced in the mid-1980s in response to consumers and policymakers' growing distaste with nursing homes, and it was designed, as I said earlier, to serve an affluent clientele, and they charge much higher rates. Many have a hotel or resort-like environment, and although assisted living care can be quite expensive, it is generally less expensive, and a lot of people don't realize this, than nursing home care. Figures from the most recent market survey show that the median monthly base rate for a private room in a nursing home is more than twice the base rate of a private room in assisted living at about $9,034 per month. But I will point out that we're referring to base rates here. Many assisted living communities charge a la carte for things like additional ADL care, including incontinence care, dementia care services, and transportational medical appointments, et cetera. So as they charge a la carte and the prices go up, assisted living also is can be quite expensive. So I'd like to draw your attention to a third, what Lepore and his colleagues refer to as a clandestine model also exists, and this model appears to be growing. And this is you've probably seen residents from this model of home in your Grady clinics as well. Research I conducted back in 2004 showed that the profit level of licensed small low-income homes is as low as $125 a month. So as you can imagine, an unusually high utility bill can put these homes in the red, and any other unexpected cost. Licensing costs and costly regulatory requirements are among the factors that threaten these homes' survival. And recent figures from the Georgia Department of Community Health show that as many as 25% of newly licensed homes are out of business within a year. So as a result of all this, we see a growth in homes operating as part of the underground economy, and it's not unusual to see a provider have one legal licensed home and one or more unlicensed illegal homes on the side to try to make ends meet. And many of the people they take in might be homeless otherwise. So there are many hospital discharge planners, social workers, et cetera, who will refer patients to these homes. They know they exist as well if they can't find other placements. And this lack of oversight and illicit nature of these homes may pose serious threats to residents' health and safety. And we're advocating that more efforts need to be made to support these licensed low-income providers so that they do not go underground or simply go out of business and are no longer available to serve the vulnerable population of residents who require their care. As I just said, many of these residents, if these homes didn't exist, would be out on the street. So this slide shows an example of a typical, more upscale assisted living. As you can see, it's very resort or hotel-like. And you may or may not be able to notice the narrow hallways. When I first began researching assisted living, many of these communities did not admit or retain residents in wheelchairs, or those who were incontinent for that matter. Today, the large majority of residents use wheelchairs, they use walkers, electric scooters, et cetera. And we often hear our research participants talk about traffic jams. Many of the communities that were built earlier when the industry was just getting started are not equipped for all the wheelchairs, walkers, and scooters. And many must schedule more than one seating for meals to accommodate all the traffic. And this is just another example of how this industry and care setting has changed over time. And I'll provide quite a few other examples of this. So in contrast, this slide shows some examples of what some small low-income homes look like and includes a picture of an owner-operator in the left corner, and also shows some of her residents. It's not unusual for the owner to live in the home with the residents, and she or he might have just one or two staff. And as I indicated earlier, our team is one of the few teams in the US that includes these smaller low-income homes in our assisted living sample, and they've been around forever. So assisted living is mostly private pay, and these fees vary considerably based on geographic location, room size, and other amenities. However, most states like Georgia have some Medicaid funding for assisted living, but this funding is very, very limited and covers only 10 to 15% of residents, and reimbursement rates are quite low. And recent figures I saw show that only about 9% of residents in Georgia receive these services. And these low-income residents who are fortunate enough to receive Medicaid services receive regular in-home health monitoring and medication management from registered nurses, as well as social work services. Currently, there are no national regulations for assisted living, although most states have a statute or a licensing category for assisted living. Many states have made statutory, regulatory, and policy changes to allow additional levels of care to accommodate increases in resident acuity. And Georgia is among states that has created different licensing categories that allow provision of higher levels of care, but still does not allow assisted living providers to provide any skilled nursing care, even if they are licensed as an RN or an LPN. And you'll find that many of these larger homes do have LPNs and RNs on staff, but again, they're not allowed under state law to provide any skilled nursing care. However, I will note that skilled nursing care can be provided by external healthcare workers, and we see a lot of that. As indicated in this slide, and as I said earlier, a growing number of assisted living providers offer separate memory care units or only serve residents with dementia. So in 2012, Georgia created 2 licensing categories. Homes that fall under one licensing category are referred to as personal care homes or PCHs, and homes that fall under the other licensing category are referred to as assisted living communities or ALCs. Until 2012, all facilities that fell under the assisted living umbrella that I've talked about were called personal care homes regardless of their size. And ALCs can offer higher levels of care and charge more than PCHs. As a result, they are more heavily regulated and have more training requirements. And in the next set of slides, I'll provide just a few examples of different regulations based on differences in rules regarding medication administration. So in personal care homes, medications must be self-administered. When needed, personal care home staff can assist with self-administration and may provide assistance only if unit dose or multi-dose packaging is used. They can remind residents when to take their medication, they can read the instructions to the resident, and they may put the medication in a resident's hand if unit dose or multi-dose packaging is used, and most homes will require that. If personal care home residents need additional assistance, such as help administering insulin, providers can have staff trained as what we call proxy caregivers to fulfill this role. And proxy caregivers are unlicensed persons who have been determined qualified to have the necessary knowledge and skills acquired through training by a licensed healthcare professional to perform what we refer to as health maintenance activities, including administration of medications. And orders for proxy caregivers are written by a licensed healthcare professional, such as an RN or a physician. And although they require certain training and work under the supervision of a healthcare professional, such as an RN, these workers, like other assisted living staff, are not necessarily well educated or well trained. They're not required to have a high school degree or a GED, but must be able to pass a health literacy test and must pass with a minimum score of 75 out of 100. So in ALCs, certified medication aides may administer medications using only unit dose or multi-dose packaging and administer physician-ordered medications. They also may administer insulin, ibuprofen, and B12 according to physician's orders and protocols. They can administer medications via a metered dose inhaler and conduct fingerstick blood glucose testing following an established protocol. And they also can administer a commercially prepared disposable enema ordered by a physician. In both ALCs and PCHs that include a separate secure memory care unit, licensed RNs or LPNs may administer medications to residents who are incapable of self-administration. And again, proxy caregivers also can perform this role in PCHs. Medication assistance in this setting is very limited, and it does not include administration of intravenous medications, central line maintenance, or complex wound care. If residents need this type of assistance, external healthcare workers are brought in to provide that. In ALCs that use certified medication aides who will be administering liquid morphine to hospice patients in MCUs must have adequate training from a licensed hospice on the safe and proper administration of liquid morphine prior to such administration. So that just gives you an idea of how the regulations are different based on how these homes are regulated differently. So this slide shows typical services provided by assisted living, and larger communities offer more variety. It includes things like 24-hour supervision and assistance. All of them provide that. Exercise, health, and wellness programs, recreational activities, religious and spiritual services, housekeeping and maintenance, meals and dining services, medication management, personal care services, such as activities of daily living and nail care, and transportation, for example, transportation of medical appointments and shopping. Although assisted living typically provides no skilled nursing care or health care, a lot of healthcare happens in assisted living, and some communities contract with external care providers such as physical therapy or a dentist to provide services several days a week on site. And they may even have an office in the community, and residents or families can pay extra to receive these services, or residents or families contract for these services individually. And some sites may partner with a healthcare system like Emory, or with independent providers to provide primary care and wellness services, such as our Emory Healthcare Domiciliary Care Program, which is run out of the Division of Geriatrics and Gerontology. And this currently serves 11 assisted living communities in Metro Atlanta. or the Emory Integrated Memory Care Clinic run out of the School of Nursing that delivers primary care to residents with dementia in a growing number of assisted living communities in Atlanta. So Emory is very involved in care in these unique care settings. So now that I've provided some context, I'll move into my discussion of care networks in assisted living. And care networks, or what we often refer to as care convoys, include assisted living staff, and that includes the administrators, executive directors, the head of memory care, the head of dining and that sort of thing. Informal care partners, and this includes, it's usually family, but it may include friends, and external care providers such as hospice personnel and privately paid care aides and residents themselves. So a statewide study our research team published in 2010 among direct care workers, it's 10 years old now or more than that. And we're currently designing a follow-up study, but the characteristics here are similar to recent 2020 national profile based on census data. The only difference is that the national profile shows a higher percentage of non-Hispanic white workers, about 52%. We have a higher percentage of Black workers among our direct care workers in Georgia. So as the slide shows, direct care workers are mostly female, and in Georgia, according to the study, more than half are Black. Based on these data, about a fifth are foreign born. On average, direct care workers are about 40 years old, but as many as 25% are older workers over age 50. And we've seen them, especially in the low income homes, we've seen direct care workers as old as 70 and maybe even 80. So as old as some of the residents, or maybe even older in some cases than some of the residents they're caring for. About 16% in the statewide study had a high school diploma or less, and close to half had no CNA training. Education and training levels tend to be even lower in the smaller board and care home model homes. So in the US, required training for direct care workers ranges from 0 to 16 hours per year. Although Georgia is at the higher end of these requirements, we find that training that staff receive to be highly variable. Whereas some providers may bring in experts from the Alzheimer's Association or other such organizations, as well as healthcare professionals to provide in-services, like somebody from Emory to come in and provide an in-service. And me and my team have done this. I've seen more than one provider supplying new employees with a video to review independently on their own. So again, the training is highly variable, and some of it's very high quality and some of it's not. As indicated in this slide, informal care partners, most of whom were family members, play a critical role in care within context of assisted living, especially for residents with complex, more heavy care needs. We find that some provide considerable hands-on care, such as feeding and dressing, especially for residents with more advanced dementia. So these, like I said, are family members coming in, feeding, dressing residents, even bathing them, in some cases spending the night. They also often facilitate and direct care that long-term care staff provide. They coordinate hospice and other healthcare services, and they monitor care quality. And we find that in many cases, without this supplemental care provided by families and other informal care partners, residents with heavier care needs would not be able to remain in the setting based on staffing limitations and/or the cost of paying for higher levels of care. And family members really work hard to make sure that their family members are able to stay in this setting as opposed to being discharged to a nursing home. Per resident, we find that informal care networks, and here I'm referring to family members and others who are regularly and actively involved in residents' care, range in size from 1 to 5 with an average of about 2. Researchers and providers often refer to residents' primary caregiver, but that is a little misleading. Often residents will have one or more actively involved informal caregiver that will, in many cases, equally share in the care of the resident. Another trend we're seeing is an increase in what we refer to as non-traditional informal care arrangements. For example, in the case of residents with no children or a spouse. And this slide shows some examples we have documented, including in some cases fellow residents. And current projections show that several social and demographic trends, including increases in childlessness, fewer offspring, and increases in divorce, will continue to result in these more non-traditional arrangements in situations where some residents lack informal support, which we find is crucial in this setting. So we see a lot of external caregivers within the assisted living setting, and this slide shows several examples. And these care providers also are essential members of residents' care networks and essential to supplementing the care that assisted living staff many with no healthcare training provided. Another trend we're seeing is an increase in the use of private care aides hired by families who can afford it. Some family members pay for 24-hour care 7 days a week that enables residents to age in place despite complex care needs that assisted living staff alone could not address. Maybe even 5 years ago, we might see a private care aide come in for a family, a couple days a week, or maybe just during the day and not at night. But now we're seeing more and more, we're seeing them there around the clock. Families may have 2 or 3 that they hired so that they have the coverage, like I said, around the clock because of the, for one thing, limitations in staffing, lack of staff training, and the complex care needs of the residents. Many of these residents just would not be able to stay in the setting without this extra help. In addition to private care aides, hospice is another resource that allows residents with heavy care needs to remain in the assisted living setting and die in place. And this family member or resident states hospice is just a great thing because essentially it's paid for by Medicare. They have 4 different people who have regular interactions with mom. A nursing assistant comes in 3 times a week. She washes her hair on Fridays. There is a nurse who sees her once a week and she checks in with me when she goes. There's a social worker who sees her every other week, and she's been a good guiding person for me to talk to about different things. And the 4th one is a chaplain. And nationally, more than 2/3 of assisted living communities in the US allow residents to enroll in hospice to supplement end-of-life care. So not all, but most. In some cases, hospice personnel interface and coordinate care with assisted living staff. In other cases, they assume full responsibility for residents' care. And unfortunately, we find that hospice is underutilized in assisted living. In our recent study of end of life in assisted living, we found that only 3 of our 7 communities, 3 out of 7, enrolled in that study regularly used hospice. And only 10% of residents enrolled in that study were on hospice at baseline data collection. And these findings are similar to findings reported nationally. And this slide shows some key findings from our end-of-life work in assisted living related to hospice. As indicated here, we found that hospice is viewed and frequently used by residents and families as supplemental assisted living care, much as they use private care aides. And this is another way that families are able to keep residents in their current home and not have to move them to a nursing home or another low-cost assisted living community. And we found that hospice agencies understand this and actively market their services in these communities by having family events and bringing in food and et cetera. Many provide regular recreational activities such as group exercise and are very much a part of the facility culture. And related to family members and other stakeholders' discomfort with discussing death, which we found is very common, we also found that residents are sometimes purposely shielded from the fact that they're on hospice. And this has been a really delicate issue we've had to negotiate when interviewing and interacting with residents. The fact that, we want to learn about end of life and what their experience is, and even what is happening with hospice. And we have a resident who doesn't know they're on hospice. In addition to underuse of hospice, consistent with the broader literature on assisted living, we also found that many residents are placed on hospice too late to receive the full benefit, often in the last month of life. So this slide provides some insight into the complex care needs of residents in assisted living. The typical resident requires assistance with more than 1 ADL. More than 1/3 require assistance with at least 3. Half have from 2 to 3 chronic conditions. 26% have from 4 to 10. And this is national data. In our recent end of life study, where we were focusing on residents in end of life, so you'd expect them to be sicker. These residents had between 2 to 13 chronic conditions with an average of 7. As noted again here, a growing population has advanced dementia and requires both dementia care and end-of-life care. And so assisted living is increasingly becoming both an end-of-life and dementia care setting, as I've said previously. Excuse me. So although the more contemporary assisted living model serves a predominantly non-Hispanic white population, this population is becoming more racially, ethnically, and culturally diverse, including adding more African-American and Hispanic residents who've traditionally cared for their own at home. And in Atlanta, we have 2 large upscale all African-American assisted living communities that started their businesses to address this growing need. And, we point out that providers really will need to keep pace with these changes to provide culturally competent care and to reduce disparities. This family member of a Hispanic resident said, whereas with assisted living, I felt like we were trying to fit a square peg into a round hole in terms of for us, it never felt like a good fit. It always felt like we're trying to make it work, but staff were not used to Hispanic family like moms. So just really not feeling like they fit in, and that the staff and the others in the setting didn't really understand their culture. In addition to growing more racially and ethnically diverse, assisted living is serving an increasing number of members of special populations, many of whom can be considered hidden populations related to fear of disclosure, such as residents aging with HIV and LGBTQ residents. This resident living with HIV viewed herself as somewhat of an outsider and different from other residents living in her community, and was careful not to disclose her HIV status. She said, these people here, they're not living with HIV. They just think that they've gotten old. And so going forward, providers will need to be attuned to the special needs of these groups and also learn how not to discriminate against them. And when this resident and her family interviewed with administrators prior to her move, administrators were very leery about admitting a resident with HIV. And they just happened to speak with one of the clinician co-investigators who was on site conducting research from my team, who indicated to them that this should not be a problem and is a chronic condition that is increasingly seen in assisted living communities and in nursing homes. And she also shared that others in their community, such as staff, are likely living with HIV as well, and referred them to additional education. So this was an incident where we observed where this resident may not have been admitted because of her HIV status. So that's a problem as well for this increasing population. As indicated on an earlier slide, fellow residents also important members of these care networks. Helping behavior is common in assisted living, and we often see less physically and mentally impaired residents helping those in need. We also see mutually helping behaviors. And here, the 71-year-old resident on this slide who said, we're family to each other, referred to himself and other residents as comrades in illness. And you can imagine how devastating the loss of these relationships was during the pandemic, in addition to not being able to interact with families in person. And I will note that the mean girls are still alive and well in assisted living, and we see a lot of cliques, but residents do develop meaningful relationships that are important to their overall well-being. So we find that one of the most important aspects of good care is the ability of different members of residents' care networks to partner effectively. And we find that some are able to partner effectively and others are not. And these family members spoke about the importance of showing respect to staff, which included really getting to know them as people and treating them as partners as opposed to hired help. This daughter said, I would say this was really important to me to get to know all the people that work with your mom directly or your dad at the facility that they may be at. Similarly, a son said, I always ask them how they're doing and listen to what they're up to and what they offer or don't offer. If there's something we're concerned about with mom, we'll ask them what their thoughts are on it. Many family members have acknowledged that care and long-term care, including assisted living, is not perfect and is a major reason why so many of them are actively involved in supplementing needed care and spend so much time in these settings, including some we've seen who reported occasionally spending the night, especially as residents get closer to death. We find that some family members are more tolerant of this less than perfect care, and we find that some seem to understand challenges that direct care staff face, including understaffing, staff turnover, and managing residents' difficult behaviors, including aggression and insults, including rude comments about staff members' physical appearance or accent, or sadly, even in some cases, racial slurs from residents who have lost their social filter due to dementia. And this daughter stated, to be quite honest, I pick my battles. Sure, the food can always be better, but I've seen worse. I just care that she can't get out the door. Safety is probably the #1 issue in terms of care. They're meeting that. Certainly, I think they're very careful. I also like the fact that if she falls, they call me. I think they're doing a good job in terms of if she cuts herself, they take care of her right away. That is the most important to me, and they're doing that. Everything else just seems to, I just kind of let it roll. We find that other family members are less forgiving and more demanding. Here, an activity director indicates that treating staff badly is counterproductive and can backfire. The husband she is describing here was very demanding and routinely talking down to staff, and he even set traps by taking pictures of things that he wanted to have addressed, such as leaving a little piece of paper on the floor and documenting how long it took to have staff pick it up. He also did not get along well with hospice workers in this setting. His complaints included things like walking in with his son and finding his wife not wearing a bra, which he felt disrespected her dignity. While this is a valid complaint and very, very understandably upsetting, the family member did not handle the situation as well as we've seen other family members handle similar situations. And this activity director said, that's how he, a resident's husband, functions in the world. That's how he communicates. So he brings that same gruffness and tactlessness into the situation with staff. It definitely shuts the staff down. It's definitely counterproductive. You've transferred a lot of responsibility onto our shoulders. So then tying our hands behind our back with liabilities, and it's not effective. It's not what's best for the residents. It does backfire. And here a staff person actually confirms that treating staff badly can backfire. She indicated that she stopped communicating at one point with a family member she described as verbally abusive. Fortunately, this relationship was repaired over time. This direct care worker said, I stopped calling her. I didn't have anything to do with her. I got to a state where her dad was declining. I discovered she got more confidence in me. She got closer to me. So in order for the different care partners in assisted living to work together effectively, we find that each group needs to gain a better understanding of one another and the challenges that each faces. Many families told us that they decided to move their loved ones out of the community, and in many cases, the family member's home to reduce burden. However, many indicated they still experience considerable burden, something that staff and others in the setting need to gain a better understanding of. Common themes from our data on family members include grief and loss, including pre-death grief, and in cases of dementia, loss of the person who once was. A sense of ambiguity is common, or the uncertainty of not knowing what to expect from day to day, including when death will come. Many express guilt. Despite trying to do everything they can for residents, many tell us that they do not feel like they're doing enough. And then some even express fear. This son of a resident with dementia expressed his fear. I know a lot of people with dementia, you start to have problems with breathing and swallowing. I just want death to be as painless as possible. And one thing we're finding in our current study of informal care partners in assisted living caring for residents with advanced dementia is just a real lack of knowledge of dementia and what is going to happen. And it does cause fear and a lot of anxiety. And so education is needed on the part of family members as well as staff. We also find that direct care staff have their own unique challenges. In addition to problems related to staff turnover, understaffing, and difficulties managing residents' problem behaviors, among other issues, we find that many experience grief in the workplace. As I indicated previously, as many as a third of residents may die in assisted living each year, so direct care staff are constantly confronting death of residents, many of whom they've developed family-like relationships with. Many staff members told us that they felt compelled to hide their emotions and grief to align with workplace norms and professional expectations. But conversations we had with staff clearly showed that many struggled with death and were in need of more support to better cope. And we find that families and others in the study may not understand these and other challenges that staff face, which may be contributing to the increasing problems we're seeing with high staff turnover. And this staff member said, I've been close to some of them that has passed on. It really bothered me. I come in and so dead. What? You got to have your cry. It hurts. It really does. You know, a lot of these direct care workers, they spend more time with these residents than anyone. They're there by their bedside, you know, every day. And many of them do develop family-like relationships and really grieve when they die. And these needs are not being addressed, we're finding. So I'm going to close the talk by discussing rapid changes in the assisted living care environment that have impacted care and care partnerships. And some I've already touched on, but we'll outline again. These include increasing competition in the assisted living market, which adversely affects some providers by making it hard to fill beds. Inability to fill beds influences providers' staffing strategies, such as understaffing, and limits resources available for residents. Another trend is admission and retention of residents with substantial physical and cognitive impairments, and the growing diversity of the resident population and increase in members of special populations. Other trends include increasing numbers of deaths and presence of hospice. National data show that 14 to 33% of residents die in assisted living each year. In our end of life study, we saw between 5 to 36% of the resident population in our 7 communities die within 12 months. A disturbing finding from this research was that as many as 45 to 80% of residents across our study had no advance directives in their resident records, although these are required by state regulations. And as indicated earlier, we're also seeing a growing number of residents with advanced dementia at end of life a population we've seen increase in just the last 5 years. And so especially given the high level of cognitive impairment in our end-of-life study and the decline in cognitive function we've observed over time, as well as the COVID crisis, the finding regarding lack of advanced directives is especially troubling and one that really needs to be addressed. Also, as mentioned earlier, we're seeing an increasing, as I've said, an increasing use of private care aides and other external care providers who are often brought in from outside these communities to help care for these residents with increasingly complex care needs. Also mentioned earlier, we're seeing increasingly heavier involvement of family and resident care and more non-traditional informal care arrangements. For example, families of choice as opposed to blood relatives. To address demand for dementia care, we also are observing a growing number of secured specialized memory care units. And then, of course, there were a number of new challenges related to COVID-19, and I'll discuss some of those that many of you may not even be aware of. So much of the press regarding COVID-19 within context of long-term care focused on the plight of nursing homes or lumped assisted living into this category when these communities have their own unique structure and needs. So compared with nursing homes, unique challenges experienced by assisted living residents and providers during the pandemic included the limited presence of trained healthcare professionals, lower staffing levels and less trained staff, and social distancing restrictions that banned family members and other informal caregivers from providing supplemental care that we find is especially crucial and essential in the assisted living setting where care provided by staff is more limited compared to that in nursing homes. So not having those family members come in was huge. Assisted living also relies more on external healthcare workers than nursing homes, and this posed additional infection threats with these workers moving frequently between different assisted living settings. So instead of having them on site, you had them coming in and out from all these different places. In addition to obvious health risks related to infection, residents were socially isolated and had limited physical activity during the height of the pandemic, which families have indicated to us has led to accelerated physical and mental decline in many cases. As previously mentioned, they also lack the critical supplemental care provided by families to help keep this from happening. Already overburdened assisted living staff who prior to the pandemic often felt pressed for time to complete care tasks also were adversely affected. In addition to the regular care tasks, they found themselves managing COVID-related fears and filling voids left by the absence of family, including often being the only ones there when residents were ill or dying, which in addition to obvious health risks related to potential COVID-19 exposure, negatively affected these staff members' physical and mental health, factors that have contributed to an already high level of staff turnover and associated understaffing in these settings. We also found that many family members experienced considerable anxiety, guilt, fear, and depression over not being able to participate in resident care like they had done during pre-pandemic times. And this is still going on to some extent. Family members are still being shut out occasionally when there's an outbreak. In fact, one family member told me that she installed cameras in her mom's room so that she could keep an eye on her when she's not able to get into her room. So it's not over yet. So as in nursing homes, low-income assisted living residents and staff and those of color are particularly adversely affected by the pandemic, contributing to prior existing health disparities. So in Georgia, our all African-American assisted living communities were particularly hard hit, and factors included lack of access to PPE, lack of prioritization for testing, and being nested in geographic locations with large numbers of minorities with higher infection rates. And then another thing to consider, in the small low-income homes where 2 to 4 residents may share a bedroom, social distancing was almost impossible. So, there was a lot of risk in these small low-income homes, and we don't even know the extent to that yet. So the changes and challenges I've outlined have created barriers to maintain the social model of care distinct from nursing homes that assisted living aspires to, and has put this industry under extreme fire. Prior to an expose published in the Atlanta Journal-Constitution that documented abuses in assisted living in Georgia, the New York Times actually published an article that criticized assisted living and questioned it as a viable long-term care option based on the increasing frailty of residents and the inability of assisted living to adequately care for this population, among other complaints. A huge focus of this article was on how assisted living is marketed as a beautiful setting and better alternative to nursing home care, but is charging huge fees for this care they're referring to as an old age nirvana, but is ripping residents and their families off by not providing the care they're paying for. And there actually is some truth to this, but the assisted living market is extremely competitive and administrators are under tremendous pressure to fill beds and to minimize economic risk. But at the same time, families often will go to great lengths to keep residents in these settings as opposed to having them go to a nursing home. So they seem to understand and to accept this, at least from what we've observed. So this is a picture of one of the more extreme cases of abuse and neglect from the Atlanta Journal-Constitution investigative series that began in September 2019, entitled Unprotected, where investigative reporters spent more than a year examining inspection records from the Department of Community Health, the agency that regulates assisted living communities in Georgia, for the period of 2015 to 2018. And they also collected information from the state's databases on fines and other actions taken against facilities based on infractions. And so part one of the series opened with a story about this 91-year-old resident and former World War II veteran from a memory care unit in an Atlanta assisted living community. The resident was sent to the hospital with 4 broken ribs, a punctured lung, a damaged kidney, and died 3 days later. His death was ruled a homicide by the medical examiner, consistent with a beating, and one of the night staff was convicted of elder neglect and sentenced to 5 years in jail. So there were no witnesses, and a medical expert for the defense argued that injuries were consistent with a fall. In the end, jurors did not feel comfortable convicting of murder, although it was clear the staff person who was caring for an entire memory care unit by himself was negligent and abusive. And then part 2 of the series reported on a female 82-year-old resident of another memory care unit who was sent to the hospital with a broken arm. She said a staff person caused by twisting her arm, and this staff person pled to a misdemeanor charge to avoid jail time. Other reports focus on falls resulting in death that the AJC attribute to neglect. And so the point that I'd like to make here is, while these cases are horrific, they've been sensationalized to represent an entire industry and vilify staff, many of whom are committed to providing good care. We find that many staff go into this line of work where they could go work at a fast food and make a lot more money. They go into this line of work because they view themselves as natural born caregivers. Many of them could not afford to go to nursing school, so this is a way to be a nurse. Reforms are definitely needed, but this and the pandemic and other factors have contributed to an already critical staffing shortage in assisted living, which is adversely affecting residents' quality of care. In our current study focusing on informal care of residents with advanced dementia, the most common reason for communities not to participate in our study has been staffing shortages. They just don't have the time. They're dealing with too much. During the pandemic and even since the pandemic, many administrators are saying that they're providing a lot of the hands-on care because they just don't have the staff. So I'll wrap up this presentation by sharing some recent changes in the regulations that have occurred in reaction to the Atlanta Journal-Constitution investigative series and stakeholder concerns regarding abuse and poor care. Among other requirements listed here, ALCs will be required to have an LPN or RN on staff for a certain number of hours per week, depending on size. Homes with more than 90 residents will be required to have an RN or LPN 40 hours per week. And these changes and regulations in Georgia and changes being made in other states, together with other recent trends I outlined, will continue to change the care environment in assisted living. And we'll gradually see this setting becoming more medicalized, which is at odds with the social model of care it was designed to provide, and also at odds with what many residents and family members really want. But these changes need to be made, especially considering the complexity of these residents and their healthcare needs. So in conclusion, I'd like to make some acknowledgements. As indicated in this slide, content presented in this talk was supported by several grants from the National Institute on Aging, or NIA, that I either led as the principal investigator or was a site PI. I also would like to acknowledge our research participants, our study team staff, and senior investigators listed here. And then my acknowledgements would not be complete without acknowledging my core team on our ongoing INSPIRE study that is focusing on improving care outcomes for assisted living residents with advanced dementia at end of life and their informal care partners. And members of this core team include my lab manager, Louise Savoy, my clinical research coordinator 3, Shremitria Massengel, and postdoc Jeffrey Lynch, as well as research associate Kiara Chan. And so thank you. This slide provides my contact information as well as additional information about my research and resources for family members and practitioners that can be found listed on our Roybal Center site and on our newly launched, as of yesterday, INSPIRE study website. And a special thanks to Jeff Lentz and Shremitria Massengel for getting that designed and launched just yesterday. So that concludes my talk, and I can take some questions.
Fantastic. Thank you so much. I must confess that was a little depressing for me as well, thinking about, aging in the supports in this country. But Dr. Del Rio, I see your hand up.
Yeah, thank you, Molly. This is, as Dr. Armstrong said, this is incredible information for us. I mean, but also depressing. We discharge patients all the time to assisted living, and we don't know where they're going to, right? We have no idea. We've never visited these facilities. We have an idea of what they are, and we really need to know where our patients are going to and what exactly is happening there. But I mean, what you're describing, what I see here is as a population ages, is a real crisis in our country. And any, for one side, you mentioned the business model, right? People are, everybody wants to get into this business because obviously there's money here. But on the other side, there seems to be a lot of lack of regulation, abuse, many other things that need to be done. So, I mean, could you talk a little bit about who should be regulating this? What should happen? Who should be the overseer? And what is the things that can be done to make this work in a better way and to take better care of our elderly?
Well, one of the issues is, as I said, there are no national regulations. It's regulated entirely by state. There are a lot of people overseeing the care of, our long-term care ombudsman program in Georgia and in Atlanta are fantastic. And, they have staffing as a result of the pandemic, they have staffing issues as well. Before the pandemic, they were going out regularly in addition to state regulators and checking in with these homes. And, they especially were concerned about this, they've always been concerned about the smaller low-income homes. And these homes had much more oversight, but things have gotten a lot more dire since the pandemic. There are a lot of advocates who are, advocating for more regulation. And it's a delicate balance because families, don't want this to be so medicalized, but, we have the change in the resident population as well, where, 5 years ago, as I said, we didn't have residents with advanced dementia who were nonverbal. Somebody who can't talk, can't tell you what's happened to them or what's going on. And think about a person who's nonverbal, who has no family coming to visit them. And, it's unfortunate. Another thing we see is, families who are in and out all the time, these residents are getting more care as well because, staff are, they're overworked, they're understaffed, so they often will pay more attention to the residents where the family members are going to come in. So, the most vulnerable are these residents, who, like I said, are can't speak, have no family, and that sort of thing. It's a huge issue, but it's one that many people nationally and locally are looking at to try to address.
Yeah, that was actually really surprising for me to hear how many advanced dementia patients were in assisted living and not in nursing homes.
Absolutely.
Definitely, yeah.
Yeah, in fact, I actually, the grant I just finished, it was a 5-year grant. We had included in there that we were going to include residents in dementia units and we made the case, which has always been true, that, residents with dementia can tell you how they feel. They can talk about their experiences. Well, halfway into that study, we couldn't recruit in dementia care units because they were so advanced. So, it just changed within that short period of time, and it continues to change. Most memory care units now are all advanced dementia. It's, you don't have a mix of people who are just need a little help. So.
Dr. Ray, you have your hand up.
Thanks. That was a stellar talk, and I feel like it should be part of the medical school curriculum and the nursing school curriculum and the life curriculum, because it's something that's poorly understood. It's like this black box of what happens. I think our social workers know about this. I think they do. It's their job, I think they assume that we know, like that the clinicians understand what we're discharging people to or not. And as I'm sure we don't have any idea in many cases. I wanted to, have you done much to explore the experience of people who are not demented living in these settings with people that are demented?
Yeah.
Is it more distressing for the person who doesn't have dementia but is very weak and disabled in some ways that I mean, they need to be there, that sort of thing?
Absolutely. I mean, in my studies, we look at, all different experiences. One thing that we found that was very disturbing was that in some cases, because it's hard to keep these residents with really complex care needs and not have them discharged. So one thing we've seen is somebody with very complex physical care needs will be put into a dementia care unit because there are more staff there and it's smaller. And so if you can imagine the distress of this person who's they don't have dementia, and they may be actually pretty mentally alert, but their physical situation is in such bad shape that they end up in the memory care unit because that's where they can handle them. So we see that, and we also hear a lot of depression. We'll hear the residents talk about, I don't like having to sit in the dining room with this person who doesn't know how, drops food all over them. It's depressing to them. They'll talk about it. So yes. But then in some cases, you see some who gain a lot of reward out of helping them. Somebody's a natural helper, you see that too. So you see a range of experience, but in a lot of cases, it is depressing for the other residents.
So we have a few questions in the chat in our last minutes about cost, and I'm going to lump a couple. One says, I hear from people that you cannot find anyone to provide care in the home for less than $15 an hour, which is $10,000 plus a month, just for the caregiver, not including food, rent, mortgage. Can you give insight on any ideas for an affordable solution for 24-hour supervision? And sort of going with that, how about long-term insurance coverage to offset the very expensive cost?
Oh, I absolutely recommend long-term care insurance. We're starting to see more people using it, but not enough people have it. And, to receive care in assisted living, a lot of people will move in and, they'll run out of money. I mean, and another thing that we see that it's distressing to residents is, they'll move in, their care needs will increase, and the families or the resident will have to pay more. They run out of money. And so they have a nice big suite. Then they get moved into a smaller suite with a roommate. Or then instead of going to a nursing home, they'll move into a lower cost assisted living down the street that doesn't provide as good a care. So we see a lot of that. But as far as finding affordable ways to provide care, honestly, I don't know what the answer is, but we do need to find more affordable ways to provide care. As I said, the low income homes, there's very little Medicaid funding for those homes. But the people who, we've observed that the residents and the providers who receive that, the residents are well taken care of. They have people in and out, they have social workers, they have RNs, they have other people coming in to see these very vulnerable residents, but it's very limited. So.
Yeah, another area of our country we need to shore up. I want to thank you so much. We're over time, but I want to thank you so much for a fantastic talk. There's lots of thanks in the chat, including the most recent one, I think, which was from all the Grady residents. So thank you so much, Dr. Perkins. This has been really, really illuminating and important.
Well, thank you for the opportunity. Bye.